Welcome to Acute Conversation, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Gus and Tricia, who are part of a research team that published a pilot study titled Consistency of Physical Therapist Discharge Recommendations in Acute Care. We discuss the results of the research, the complexities of discharge planning,
and opportunities to improve consistency in our recommendations. Let's welcome our guest.
All right, welcome to another episode of Acute Conversations, or a podcast. Today, we've got two researchers hailing from Brooks College of Health Professionals from their DP program in Indiana. We have Dr. Gus Almonroeder and Dr. Tricia Widenhoefer. Thank you so much for being here today. I just wanted to call the fact that you were featured in our Jackpot Journal, Journal of Acute Care Physical Therapy, Volume 15, number 4. So earlier this year in the summer, so fresh off the press. Could you maybe just give us some insight to what that article was about?
Do you want me to take it, Tricia?
Yep, you take it.
Perfect. So kind of wanted to look at consistency of the discharge recommendations made by therapists with acute care experience. So we created kind of a collection of clinical vignettes, kind of fictitious patient cases that reflected patients that were in an acute care setting. We distributed kind of to our local network of therapists here in the Fort Wayne, Indiana area, and then asked them to review the cases. And it provided information, they're a little bit about their medical history, some, things about do they have home support, their physical condition, those kinds of things. And then asked the therapist to make a recommendation, home with therapy, outpatient therapy, long-term acute care, subacute care, all the kind of, options that you may consider as an acute care therapist. And then we looked at the consistency among those different options. And our idea was to kind of look at, how consistent is decision making among acute care therapists with making these recommendations, because we knew that's a key part of one of the key functions of, being an acute care therapist is making those recommendations. That's a really critical aspect. So that was kind of the crux of our study.
Very cool. Looking at the study, I really enjoyed the fact that at the very end, in terms of like just looking at the different citations that you have, a lot of the research that you had looked at in preparation and for writing this article, researchers talking about what is it, the Smith article, the Jetty article, just talking about the accuracy of discharge recommendations, the importance of discharge recommendations, when PT discharge recommendations are not followed and they're not matched, how there can be detrimental effects. Could you maybe talk about what this article adds to the literature that's already out there?
Oh, well, we kind of wanted to look at it, and Tricia and I were both on the same page with this. We wanted the tone of the paper really to not be, hey, therapists are missing the mark on making these recommendations and things like that, because there are some of those papers. There's a good collection of papers, like you said, the Smith article, Jet paper, that have really shown that therapists make really good recommendations when patients are discharged to the locations that's recommended by physical therapists. They're less likely to be readmitted to the hospital. They're less likely to experience falls and things like that. So it was kind of looking at it and saying, therapists are in a good position to make these recommendations, and they're doing a great job, but there's always room for improvement. So if we can keep, a small fraction of those patients from being readmitted to the hospital, or having a fall where they might have an injury or something like that, I mean, that can have a big impact on somebody's life and on the healthcare system and stuff like that. So we kind of wanted to take those papers and just say, yes, there is still some room for improvement. And the first step in that, I think, is to look at, okay, how consistent are therapists to begin with? And that was kind of the, one of the frameworks we wanted to use, or the tone we wanted to set for the paper is, this certainly isn't, we need a complete overhaul of the way we do things and stuff like that. There may be opportunities to bolster some of the things we already do pretty well as therapists.
I have to say, I find this paper fascinating. I just find this whole topic fascinating. I'm somebody who teaches acute care, cardiopulm. I teach discharge recommendations to students. And it's one of those areas where I feel like it is so vague and they really struggle with it. But it's really interesting to me to see because, in practice, you talk with your colleagues and you're like, yeah, we all agree on this discharge recommendation. But I've never really thought before about comparing what would I recommend for this patient versus what would another PT recommend? Because to me, it's crystal clear. But I was also noticing the range of experience that the therapist in this paper had from 1 to, was it 30 something years? So I was curious, did you all look at all about how different did the people with more experience tend to recommend similar things versus those with less experience? I know you didn't have the power to do a lot of that, but just did you play with it at all? I'm just curious.
And I think that's kind of the direction we're headed in the future, just to be able to get a larger sample population to be able to do some of those correlations and just to play with those, because I think anecdotally and in our minds, that definitely plays a role, but just to be able to have that, the hard facts and evidence to support that. And I know in my prior experience before going to academia, I worked in a health system and I would have case managers, say, your therapists need to get on the same page when it comes to recommendations. And I would be like, I totally understand where you're coming from. Please understand when they go into the room, they may be catching the patient at different times and seeing different patients. So they're making their recommendations based on that. So they're not always going to be consistent or an agreement, and we were talking about students and definitely those new grads right out of school. Those were ones we would kind of spend extra time with when it came to discharge recommendations, trying to get them up to speed and having mentors for them so that they could feel good about the recommendations they're making.
And one of the things that Tricia really, it was her idea to look at this when we started to develop the survey that we were going to distribute and stuff like that, was to look at not only the years of experience, but did the therapist have experiences in other settings besides
Yeah.
acute care? Because I think we didn't have the data, like you said, we just didn't have the number of therapists, and that's where we're going with the next steps for this, is just to expand our sample size a little bit so we can tease some of that out. But I and she made the great point. I would totally agree. It may probably make such a difference if you spent some time in, maybe a skilled nursing facility, inpatient rehab, some of these different settings. So you kind of see the other side of it. You know what I mean?
No, I completely agree with that. I can tell you as somebody who I always joke and say, I didn't really know what I wanted to do. I practiced for 10 years, literally practiced in every setting: outpatient, home health, inpatient rehab, acute care, outpatient. And I will say that once I settled in, I was like, I love acute care. I think it really helped me because I could visualize what the patient looked like in their home. I could visualize what the inpatient unit was like because I worked there. I could visualize their lives, what an outpatient can look like and what the patient needs to be able to do to get to and from. So I do think you're right, Tricia, that that really is probably very beneficial. I also think, as somebody who has seen patients in real life and made discharge recommendations, and as somebody who gives clinical vignettes to students, I sometimes think there's a lot of value to seeing that patient in person. And I also wondered that if you said, hey, here's a video of this patient and their quality of movement and how the family interacts with them, if that would even make a difference versus just having it all on paper. What are your thoughts on that? I'm just curious.
I think that you definitely would make a difference just getting to see them in real life because, people present one way on paper, but when you see that, you may be thinking one thing and they're doing something totally different. But definitely that real life experience would make a difference, I think.
Leo, I'm just curious about your thoughts as an educator, someone who's read the paper, somebody who sees patients. What's your perspective on this?
So that was interesting. So just in terms of the setup of the study, first all, it's the pilot study. So hopefully we can see this being branched out even further. I think it's a good start, right? There's at least, because that's similar to what we do in terms of getting a chart review, right? We get our chart review, get the information, we have X, Y, and Z, but it also spells out that while you look at this chart review, our minds are already going and thinking about what are some possible discharge plans. It's so funny working with students. Sometimes we're doing things that we don't need, just subconsciously. When I'm looking through that chart, okay, we're already looking up, we're picking up, okay, what are the lab values? What's their diagnosis? What's their living situation? Do they have family members? And so with that right away, we're starting to kind of put these pieces of the puzzle together. A more novice clinician or a student wouldn't even start to consider those things because they only see the medical component. So what was interesting too is that looking at this, you had a good range of people with different experiences. I think the average age or the average uh, time practicing was 14 years, but it was there was some spread, right? There was some that were like new grads, and there's some that had many years of experience, and just trying to figure out, okay, can they still come up with similar discharge plans for those patients?
And that's something I cover in my class because I want, I love acute care, kind of like you, Ashley. And I want our students to go out and be excited about it and feel like they have a little bit of an idea of what happens there. So I do share some vignettes with our students in class. And, we talk about the different levels of care. And I'll say, okay, where do you think this patient should discharge to? And then we talk about it. And then I say, okay, what would need to change in order for that patient to get to go home versus then patient rehab? So kind of talk about some of those other factors. Well, if the patient had this instead of this, how could that affect the discharge plan? Or what are some other things that the patient would need in order for the discharge plan to change? That's been a lot of fun. And I think the students like it because they can readily apply it when they go out on clinical.
I'm curious to go back in time a little bit. I'd love to hear a little bit about the two of you. What are your backgrounds in acute care and what got you interested in this topic in the first place? What made you feel like, oh, let's do this pilot project? So I'm going to start planning. I mean, I'm sure there was some precursor, like there usually is for research, that was like, let's do this.
I'm gonna highlight Gus here. Gus is the mastermind behind this. He was just reading something, and all of a sudden he's like, "I think this is a great idea." And then he's, "Hey, Tricia, what do you think?" And I'm always on board when Gus calls and has a project.
He humors me a lot of times because my ideas go all over the place. But yeah, I don't have a lot of clinical experience in acute care. It was actually Danny Kahneman's book, who is not a therapist, but was kind of a psychologist, but has also, had a major impact in his research on economics and all different areas. And he had published a new book. I've always been a fan of his writing and stuff like that. And he had published a new book called Noise. It was published a couple of years ago, and I was reading it, and he was talking about human decision making, right? In all these different contexts, right? Like, judges doing sentencing and reviewing the same case and coming to different conclusions about what an appropriate sentence was. And then physicians making medical diagnoses and admissions committees admitting students or not. So he was talking about all these things that contributors to inconsistencies in decision making. And I'm kind of reading this book, and I kind of put it down. I'm like, well, what's a therapy example? And I kind of played around with a lot of different ideas. And I was like, well, based on my very limited experience in that as a student, and then I practiced, for a short amount of time in a few different settings and things like that. I was like, that call, that recommendation about discharge is so complex. There's all these different factors to consider, and things can change quickly, so there's a little bit of a prognostic skill that you have to have and stuff like that. And also the stakes are high. You know what I mean? Because again, we're talking about readmissions and people going home when not getting the support they need and all the things that can happen there. So I kind of was like, that looks like an opportunity where we could use that framework that Kahneman had described in his book and really had been the basis for his research, and take that, and can we apply this to an acute care setting? And that's when I kind of called Tricia, and I'm fortunate that Tricia picks up the phone most times when I call, and chatted through the idea. And it was kind of like I kind of read the book and came up with the general idea, but it's one of those things that's been an awesome partnership because I'm an ideas person. I have a lot of ideas, but I rarely can execute them. And Tricia, been able to really take that really nugget of an idea and take it and refine it and come up with a great idea and really structure this study. So she's always going to give the credit to me, but I would give the credit all to her because I don't know what this study would have looked like without her background in acute care and her expertise. So it was a good partnership on this.
While I was reading this, I noticed you had also referenced the core competencies of entry level care, being an entry level practitioner. And a big part of that is going to be our ability to make discharge recommendations. So I applaud the two of you trying to put some science behind figuring out what's the consistency and the correlations between multiple practitioners. But what's interesting is I also like to look at it from both sides. What about people that would challenge us as therapists, right? Because sometimes we get a lot of that. And Tricia, you had alluded to that a little bit too, about if there's inconsistencies. So this happened. I know this happens to me while the case manager, social worker will say, this patient was evaluated a couple of days ago. Can you change the discharge recommendations? Can you see them and update them? Now there's a difference. Or based on the profession, whether it's PT and OT, maybe there's differences in terms of the discharge recommendation. So I would say people that would gonna challenge us as therapists and challenge our profession would say, look at this, it looks like it's only fair in terms of the correlation between these practitioners. Or people say that therapists can give accurate discharge recommendations that even within this study that shows that there's not super high correlation. How would you respond to that?
I think there are a bunch of different responses. As evidence has shown, when you do find recommendations, again, there, the chance for readmission is lower, the chance for falls go down. So I think it shows that, hey, we are the movement specialists. We are definitely kind of the players who should be making recommendations. And then again, like Barry, I think that's where you need to have that conversation, get together and talk about what did you see that I didn't, what did I see that you didn't, and then if need be, go back in there and check that patient out just to make sure that that patient is ultimately getting to the right level of care. And that's what that's all about, is taking care of that patient.
I want to go back. I want to go back because I find it fascinating that you came up with this idea from reading a book about something completely different. But I'm kind of curious now that you're doing this pilot study and you had this initial idea and the two of you came up with this, where do you see this going? What's the next step for you?
Yeah, I think that's a great point. It's like, you know how it is. Like you get done with one study and you rarely get the chance to celebrate because it's like, well, what's next? You know what I mean? And that's just how you're kind of trained. And it's hard to get out of that sometimes. But we looked at this and I think the next step is probably to tease out some of those different factors, clinic years of clinical experience, training level, experience in other settings, those kinds of factors that can influence consistency that we would need a bigger sample. That's probably one because those came up with the reviewer comments when we wrote the paper. And so it was nice, right? We got really great reviewers on this paper. They were obviously got published, but more importantly, they really helped to improve the paper. Their comments were helpful, and they brought up great points, and they actually gave us a lot of ideas for what the next steps would look like. And then I think even beyond that is there ways that we can kind of intervene to improve consistency? And I think that could look a lot of different ways. I think that could look in the form of something like an educational workshop where therapists get together and discuss different cases and discuss the factors they weight and stuff like that. And maybe they close the loop with getting case managers involved and things like that to provide their insight. I think those kind of educational workshops could be a way to improve consistency and then hopefully obviously improve clinical outcomes. And then other things like leveraging predictive modeling and things like that, like we've used in other areas of medicine to say, the kind of with an informatics spin to it. And again, we tried to be clear about this paper. It's never going to be that, those models are going to replace therapist decision making or anything like that. But could they be useful for augmenting our decisions, right? Because it is complex and there are a lot of factors to consider. And that was one of Kahneman's points in the book that, there's things that like predictive models or, mathematical models, statistical models are really good at. And then there's things that humans are really good at, and they're kind of distinct, right? So it doesn't always need to be those things are competing against each other. It's can we leverage predictive models to make us better versions of ourselves? And like I said, there are examples of that in the literature about, do you admit a patient to the hospital or not? If you're a physician or something like that, that I think we could leverage. So those are some of the next steps is what are the factors that influence PT consistency and stuff like that? And then how can we essentially actively intervene to improve consistency and improve outcomes? Or at least the way the steps I think are next. I'm not sure if Tricia has some different ideas too.
I agree with you. I'm always up for your project.
Gus, Tricia, I had a question for you. I was really interested in seeing you reference from a medicine standpoint. For example, if somebody has like community-acquired pneumonia, there is a predictive model of making that kind of clinical decision between whether we admit a patient or a patient gets admitted, or if this can be treated from outpatient. So there are these kind of predictive models. And then there's always been talk about using outcomes, right? One of our former guests from the podcast that talked about using outcome measures to kind of help predict. But then there's a little bit of kind of statistical gray lines, right? Like the difference between a predictive model versus there's correlation, not necessarily causation. There's correlation without going too deep into the statistical woods here, could you maybe explain how those are a little bit different? Like, I can say that patients on the Boston Impact, when I look at all the patients being discharged from my hospital, I can correlate that patients that get a score of 18, those are the ones that usually go home. If it's less than 18, they usually go to some type of like institutional setting. But that's not necessarily a predictive model. That's just showing that based on the outcomes. Can you maybe just talk a little bit about how those are different?
Yeah, oh, for sure. And the hard part about that kind of predictive modeling is, the first step is really to say, can we create kind of a cut point in a lot of these scales? And the hard part though is that cut point is largely those times a lot of them are purely statistical, right? And the patients that you really need those kind of predictive models for live in the boundaries, right? There's patients that are obviously this patient should be discharged to home, or if you're talking about, like acquired pneumonia or something, you're saying obviously patient should be admitted to the hospital. And then there's patients on the other end that it's like obviously this patient should be discharged to skilled nursing, or obviously this patient shouldn't be admitted. But the hard part is that most of the patients that we really are challenged with and that we have to use those models kind of live in the boundaries where, you know, mathematically what shifts them over the line one way or the other is a lot of times very subtle. So that's where it's like, yes, we can find cut points and we can find differences, but that doesn't always tell us that this is going to be an effective model that we can really use and is going to be useful for our clinical decision making and stuff. So developing those predictive models and stuff like that is usually a kind of multi-step iterative process where it's collect data, start to get those cut points, then say, can we classify patients in any kind of accuracy? And then does using the model actually improve our clinical outcomes and our clinical decision making? So it would be an endeavor to do those kinds of things. That's to me as a career as a researcher to get those things going. So that's where I view it. And it's interesting when you bring the community acquired pneumonia, example from medicine. My wife was actually a co-author on the paper, and she's a physician assistant. And that was her big contribution to the paper. She contributed in a lot of ways. She'll like that I give her a shout out in this. But my wife's in family practice, and I kind of, picked her brain a little bit to be like, all right, you're not a therapist, but then she gets the idea of what the paper was about, obviously. But I'm like, from the medical side of it, what are some analogous things that you kind of use, to make these types of tough decisions? And she came up with a few examples. That was just the one we had in the paper. But, I think there are templates for us, but even those models that they're using to determine, admission or non-admission, those kinds of things, it's been a trajectory. Like it's taken a long time to get where those are useful. And they're still at the point where it's a lot of gray area. There's still patients that probably fall through the cracks because they're right on the boundaries with those kind of cutoffs and stuff like that.
So when we started talking, I wanted to bring up a paper that was published in PTJ a while ago that found patients are almost 3 times more likely to get readmitted when a physical therapist's discharge recommendations were not implemented. And I think that paper really validated our role on the interdisciplinary care team. But your pilot study showed there's still room for improvement. You're saying, what can we do to make this a better process? And you use case scenarios, but I think it would be really interesting if we take a real patient who's in the hospital, follow the primary PT's discharge recommendation, but also take note of different PT's discharge recommendations. Then we follow these patients after discharge to see what the outcomes are. We could look back on the various recommendations made and reflect on the specific outcomes when a certain discharge recommendation was followed. It would just make for a more reflective process.
What I think is great too is the fact that there's a lot of, there's sometimes fear that artificial intelligence and, can we reduce everything that we do just to an equation, right? Just plop some numbers in and just like, well, what's so skilled about that is like if you made some gigantic algorithm, right? You put the numbers here, 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 and it just spits you out an outcome. But there's a lot of nuance though that doesn't get captured, which I think also this article kind of shows. Like we're in the pilot program, we're gonna start off with these vignettes, but then taking another step further, what happens when therapists are there on the actual floor with these patients? But I like how there's information here that we can kind of glean. And again, a lot of the other resources that you had cited. But there's a lot of, there's a lot of things that we have to consider when we're making these discharge plans, like those. And again, it could be one small, all of a sudden we didn't know that the son is on summer break right now. They're going to be available for the next 2 weeks. So instead of going to inpatient rehab, we could do home health. Like there were all those little nuances that I don't think that artificial intelligence would be able to just take over our jobs from that standpoint, in terms of discharge recommendations. But I think the outcome would be kind of this hybrid model where we can use these models. Gus, I like how you had kind of put this together. There's certain things that computers and AI and the technology can do well, but the human brain also does very well, and they're different. And when we work together as a hybrid, then we make some great outcomes from it.
Oh my gosh, that would be so scary if AI were making discharge recommendations, would it not?
It would be, and I love that point too. And I always talk to students about this in different courses and stuff like that to kind of tell them, artificial intelligence and machine learning and all these kind of different approaches are here to stay. They're not going anywhere, and they're going to be a big part of your life. And the way you practice today is not going to be the same as you practice 10 and 15, 20 years from now. But I'm kind of in the same vein. And I'd probably, most people would look at me and be like, oh, he's a math guy. He likes statistics and all that stuff. The reality is, I think that we can leverage those. And if you're not kind of comfortable with leveraging those, it's going to pass you by a little bit over time. But on the other end of the spectrum, there's going to be this tendency to maybe overly rely on artificial intelligence as models. And in my mind, the skilled clinician is going to be the ones that can get a recommendation and but understand what factors make it not pertinent to this specific patient. Like you said, Leo, it's like this is recommending that this patient be discharged to home. And while that is true for 99% of patients with these characteristics, there's one unique thing about this patient that makes a difference. You know what I mean? So that's where it's like there's never that tendency to say we completely rely on it or we shut our brains off, because that's going to be the great clinician, the person who could say, what is the one exception out of 10 or 100 patients that have these similar characteristics that really make them unique? You know what I mean? So I always tell students, it's like, you're not going to be replaced. Your judgment going to be replaced and all that stuff. But you are probably going to need to learn to work with it and leverage it a little bit and stuff like that. But we're all learning how to do that over time. As educators and clinicians and researchers and writers, whatever you do, we're all just in this point of like trying to figure out what it can do well and what it can't do well and what it can replace and what it can't replace. But that ability, I think, is going to be the key in my mind.
I also think that AI is not in the perfection. So when we're walking in there, I'll live with my daughter's feeling home at night, that kind of adds another element that I can't pick up.
Yeah,
So,
because we talk about AI like, hey, it can model all these complexities. And it's true, it can model a lot of different multifactorial things. But you know what? Life is much more complex. Those models, they'll never be as robust as someone's day to day and their life circumstances. And like Tricia said, yeah, they've got somebody at home, but you really have to do some of the detective work as a clinician to figure out, is this person dependable or are they just there? Are they going to be able to help? It's never going to get to the point where it's going to be able to dig like a great therapist can. And I always tell people, I'm a therapist, but I don't consider myself a great therapist, but I know a lot of great therapists, right? And I think one hallmark of great therapists, whether they're in acute care or skilled nursing or outpatient therapists or therapy or sports medicine, is they're detectives, right? They keep digging and stuff like that. And I think acute care therapists that can do that and really find out what's going on and through a lot of different sources and stuff like that are the ones that can really, really drill to the core of what needs to be considered,
Gus, you wrote a book. Can you please share? What book is it? Should we check this book out?
Yeah. So a few years ago, I wrote a statistics book. It was kind of geared toward students that were training to be health professionals. So PTs, OTs, students, in medicine and stuff like that, with the idea of kind of demystifying kind of statistics. And because I teach a lot of those types of courses to the PT students, and I taught them to some other students, and that was kind of more of a textbook format. And then last year, I kind of wrote study strategies book, kind of a smaller book that was kind of just study tips for students and stuff like that. And so writing's always been something I enjoyed. I like scientific writing. Up there it is. She'll always prepare me more. But I've always enjoyed writing. I enjoy scientific writing, non-scientific writing. If I could, I'd probably retire, move out west and write the great American novel if I could. I've got a mortgage and kids and stuff. I can't do that. But yeah, that's something that was fun for me. And first book was really a pandemic side project, to be honest. It was one of the things during the quarantine where I was like, I can't really be on campus doing some of the research I need to be doing or I should be doing and stuff like that. And I was like, well, I need something to be occupied. So that was where that kind of came from.
And Tricia, there's something really interesting about you too that is not typical. Tell us about your twin.
My twin, yes, I have a twin brother, 11 sisters, and we have different birthdays. And he was born before midnight, and I was born after. So I am the youngest, and he always tells everybody I kicked him out, get him out of the way.
Barely.
How many minutes apart?
16.
He's older, right? You just don't hear about twins with different birthdays. That is fascinating.
It's been a lot of fun. And that's, in school, I'd be like, oh, we're going to celebrate your birthdays. And I'm like, well, his is, tomorrow, mine's the next day. And we kind of stop. And
2 days of festivity.
So before we do our rapid responses, is there anything else either of you wanted to share about your research or anything you wanted our audience to take away that we haven't mentioned?
Yeah, I would just say it's been fun to be on this with both of you, and it's always great when your work gets acknowledged in these, more than just people reading the paper, but reading it and wanting to discuss and ask questions about it and stuff like that. As a researcher, there's nothing better, right? That's the motivation and things like that. So it's just been fun to be a part of this for sure.
And I would just, a big thanks to Gus. He's awesome. And you can, tell that from this podcast. There's no better person, no better coworker to have than him. And I'd also like to acknowledge the students that helped us with this. They were just so much fun and just so enthusiastic about this project. And we've been coming up with the cases. You could just see their eyes light up like, oh my gosh, I'm going to do a case about this. And so they were just a great group to work with.
Gus, if I'm ever in Indiana and I have a copy of your book, hopefully I can get it signed by you.
Yeah. Consider it done.
Awesome.
Well, thank you both for your work. We really appreciate it. I think it's time, Leo.
I think it is time. So,
Yeah.
Gus and Trish, are you familiar with our rapid responses? We're going to give you a minute. We'll probably just go back and forth. We're going to be asking you questions and you just come up with the first answer that pops up into your head.
Let's do it.
I'm going to give you an extra 30 seconds. Are you ready, Leo?
You want me to ask the first question?
That's all.
I'm on it.
Ready and go.
All right. Let's start with Gus. What's your most favorite way to exercise?
Exercise, probably swimming. I don't do it as much as I should or as much as I'd like to, but it feels good as I get older.
Less impact. Yep. Tricia?
Tennis and walking while reading a book.
Very cool. Awesome.
What book would you recommend to our audience that you haven't authored?
I haven't authored a book. I like to read mysteries. So you'll catch me walking around the neighborhood with a book, and I've only tripped one.
Gus, how about you?
It's not any specific book. I just love picking up random books that people give me or that I find different places, or I'll go to the library and I don't read the cover. I just look at the title, look at the feel, and I just start reading it. And sometimes it's terrible, but I just keep going till the end. You know what I mean? And it's just like, I've always liked doing that. So I read self-help books and I'll read, DIY books and finance books and all these different things. And, it's just interesting.
Here's the question for the two of you. Name a therapist that has been influential in your profession. To you.
For me, I'm going to say Colleen Hahn. She's one of the therapists that I've worked with for the past 26 years. Just a great therapist, great mind, great customer service. She truly is about the patient. So I've learned a lot from her.
I would say Matt Haberl, who is a therapist I worked with as a student. during one of my first clinical rotations, and Matt and I became great friends and still stay connected and stuff like that. But he pushed me to think in ways that I probably would have never got to without him and stuff like that. But in good ways, he pushed in good ways, right? That it always made me challenged me, but
Right.
also I knew I could always kind of lean on him when I needed. That he was a great mentor that came at the perfect time in my career.
Well, that's our time. One last question. You know you work in acute care when?
You take part of the patient's home with you on your shoulder or your
I would say when you've got over 10,000 steps by like 11 o'clock in the morning.
This patient canceled, go to the 7th floors, or that
Yeah.
patient canceled. Their next, I gotta go to the 1st
Yeah,
floor.
exactly. You definitely get to know the ins and outs of the hospital when you're in acute care, right? You're like every nook and cranny and every person. It's like, man.
Especially if you're all over the place. That is so true. Well, thank you both. Thank you so much. I really appreciate you trying to make our practice a better one.
Thank you.
Yeah.
Thanks, Gus, Tricia. All right.
Awesome. No, thanks for having us.
Thank you. Thank you.
You guys.
We would like to thank Gus and Tricia for joining us on the podcast. Acute Conversations is the official podcast of APT Acute Care. It is hosted by Leo Argulis and Ashley Poole. Executive produced by Candy Brito and Edward Mackes. Music by Alexi Action from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Brian Hull and Amelia McCune about Falls research. Thank you for listening, and may your shoes and scrubs stay clean today.
And now I read. I have a daughter who's 7, and we read. We're starting to read chapter books and things like that. And I'm trying to like instill that mentality in her for some reason. Like I'm just like it feels weird to me when she's like, "I don't like this book. Can we switch?" And I'm like, "But we're not done yet."
They never started.
Yeah, exactly. I'm like, well, we're not done. It's like the Boxcar Children or something, but you know what I mean? Like, it's like, still, you have to finish it. And I'm like, well, if you're not going to finish it, I'm going to take it and finish it the later when you go to bed. But it's funny. It's a weird quirk.